Okay, welcome back to this four-part series. Right now, we are going to go into Module 2, and that is the module on tobacco. Once again, thank you for joining. And this learning series is funded by SAMHSA, the Substance Abuse and Mental Health Services Administration, with a grant to the National Latino Behavioral Health Association to operate the National and Hispanic Latino Addiction Technology Transfer Center. We want you to know, by way of a disclaimer, that the views, opinions, and content expressed in this presentation do not necessarily reflect the views and opinions of the National Latino Behavioral Health Association, NABLA, or the Center for Substance Abuse Treatment, CSAT, and the Center for Substance Abuse Prevention, CSAP, or the Substance Abuse and Mental Health Services Administration. Once again, thank you for joining. The mission of the National Latino Behavioral Health Association and its goal is to influence national behavioral health policy, to eliminate health disparities in funding and access to services, and to improve the quality of services and treatment outcomes for Latino populations across the U.S. You can see that the executive director of NABLA is Fred Sandoval. The objective of NABLA is to provide national leadership on mental health and substance use concerns of the Latino community. NABLA's policies are the following: targeted capacity expansion of mental health services for Latinos and Latinas, Latino behavioral health evidence-based practices, legislation to increase the number of counselors, therapists, and other behavioral health practitioners in the field, funding for co-occurring disorders of alcohol and substance use, opioid crisis in the Latino community, as well as suicide prevention. The TTCs are funded throughout the country by, once again, SAMHSA, the Center for Substance Abuse Treatment, the Center for Substance Abuse Prevention, through the center at the national level. And there are 3 different types of TTCs, what are known as technology transfer centers. First, there are the prevention technology transfer centers. There are the mental health technology transfer centers, and there are the addiction technology transfer centers. And you see that this is quite a busy slide, but there are TTCs all over the country. We here at the Addiction Technology Transfer Center, the Latino and Hispanic one, encourage you to take full advantage of these resources that are funded by our tax dollars. All of these centers are funded to provide technical assistance, support, and guidance to individuals and organizations across the country and in our field. And there are many specialty TTCs that you can take advantage of as well. In terms of the mission of the National Hispanic and Latino Addiction Technology Transfer Center, it is to provide high-quality training and technical assistance to improve the capacity of the workforce serving the Hispanic and Latino communities in behavioral health treatment and recovery. We disseminate and support the implementation of evidence-based and promising practices to enhance service delivery, promote the growth of a diverse, culturally competent workforce, and bridge access to quality behavioral health services. We are committed to increasing health equity and access to effective culturally and linguistically rounded approaches in the work across the country. In terms of staff to introduce you to today at the National and Hispanic Latino Addiction Technology Transfer Center, those include the director. Her name is Dr. Susie Villalobos. She has worked in academic institutions and not-for-profits as a public health advocate, researcher, by implementing and managing clinical and social behavioral studies and programs. Her expertise in working with local, state, and federal agencies stems from her associations with community-based organizations, focus on activities committed to committed to focusing on health disparities among the Latino population living and working in the U.S., as well as the Mexico border. Again, she has many years of experience, and I encourage you to read the full bio. Next up is Ana Chavez Mancilla. She has a master's in social work. Prior to her position here, Ana worked for Pacific Clinics for over 18 years as a bilingual, bicultural mental health and substance use services, providing substance use services to children and families. Over the years, she has held different positions and roles within Pacific Clinics, including substance use specialist, case manager, therapist, program coordinator, team supervisor, and program director. You can once again read the rest of her bio to yourself. So we have very competent people at the helm and working within the National and Hispanic TTC. We encourage you to get a hold of staff if you're looking to access training, technical assistance, support, and guidance around these subject matter areas. I am today's presenter. My name is Janet Hernandez, and it is a pleasure to once again have you here for Module 2. I am the program director of the Latino Addiction Counselor Education, also known as LACE program in Massachusetts. We're funded by the Department of Public Health to do that work. I also provide clinical supervision to doctors, nurses, recovery coaches, and other staff, including case managers and medical assistants at a federally qualified health center. And there we are doing MAT/MAR work, so medication-assisted treatment, as well as HIV work and hepatitis C work. We have cured over 250 people with a 99% cure rate. And once again, this is Module 2. You notice that I have, I'm a certified prevention specialist. I'm certified and licensed as a drug and alcohol counselor. And I want you to know that I have over 34 years of experience in the field working with a number of agencies at many different levels. At the local level, at the state level, and at the federal level, I provide training, technical assistance, and guidance to a number of organizations that are funded by SAMHSA, HRSA, and CDC. I am committed to eliminating health disparities by building equity in the field. The other credential that I hold is a PhD, and I want you to know that I also have a GED, and my GED I got in prison. And I am a person in long-term recovery, which for me means that I haven't used a drug, including alcohol, for the last 35 and a half years. That enables me to be a productive member, first and foremost, of my familia, to be able to do this work on the ground, to be a productive member of my community, and to learn from and work with people like you on the ground who are doing great work. So it's a pleasure for me to be here with you today. Once again, in terms of the outline, we completed Module 1, which was on alcohol. Today is Module 2 on tobacco. After this one, we are offering Module 3, which is on opioids, and Module 4, which is on stimulants. And we encourage you to take these in order and to take them all, and to encourage other people from your agency, contact list, that sort of thing, from the communities to go through these modules. And hopefully there will be benefit to you, to the people that you serve, and other people on the ground. In terms of our outline for today, in Module 2, we're going to be doing an introduction to substance use disorders in the Latino population, followed by tobacco use, and then the treatment of tobacco use. Obviously, all of this within the context of engaging, treating, and improving outcomes for the Latino population in the U.S. In terms of an introduction to substance use disorders, we're going to focus in on what the DSM-5, the Diagnostic and Statistical Manual of Mental Health Disorders, says around substance use disorders. And effectively, it says that SUDs are a constellation of behaviors involved in compulsive drug seeking, including impaired control of substance use, impaired social interactions with others because of substance use, risky drug use. This includes substance use in hazardous settings and pharmacological changes, which include withdrawal symptoms. Addiction is at the most severe chronic stage of a diagnosis of substance use disorders. The addiction is characterized by substantial loss of self-control, manifesting in compulsive drug-seeking behavior, despite the desire or attempts to discontinue substance use. And so that's the grounding around what the DSM-5 says around substance use disorders. And most of us who utilize the DSM as a tool to diagnose people are familiar with this. If you are not, we encourage you to take additional training on the use of the DSM. Here is our question for this module to consider. What do you think about the non-smoking policies in schools? Do you think that they help to decrease or increase the numbers of students that smoke? And so we, in terms of thinking about this problem, consider the following. I am old enough to remember where people smoked in all sorts of settings, including theaters, public spaces and places, and public buildings and private buildings. People smoked on planes, in doctors' offices. It wasn't unnatural to see even a doctor smoking or promoting cigarettes, that sort of thing. In school settings, people smoked, all of that stuff. And after we developed a lot of awareness around the impact of the use of tobacco products as well as secondhand smoke, we developed policies as a country that are now standard policies across the public health spectrum and beyond, into businesses and other companies, that sort of thing. And we have seen the numbers of people who are addicted to tobacco drop. We've seen the impact of tobacco use lessen by way of mortality and morbidity. And we have seen the benefits of these policies in schools, both private schools and public schools. So when consistently enforced, school non-smoking policies are associated with decreased smoking prevalence among adolescents. And you see the reference there. I expanded above and beyond just adolescents because we have seen positive gains across the board in society when we implement policies, sound and well thought out policies regarding tobacco use. So once again, here we are around tobacco use disorder. We're going to go straight into it. In terms of tobacco use in 2019, it's estimated that 14% or 34 million of US adults were current cigarette smokers. And current cigarette smokers are defined as people who had smoked more than one cigarette during their lifetime and continue using cigarettes every day or some days of the week, right? So that is sort of the definition. And you see the number of people here who are adults who are impacted. 34 million in a country of 340 million is a huge number. In other words, 14%. Cigarette smoking causes about 1 of every 5 deaths in the United States each year. That's 1 in 5 deaths, right? In 2014, cigarette smoking, including secondhand smoke, was estimated to cause more than 480,000 deaths, right? That's in a 1-year period. 278,544 of those deaths amongst men, and then 201,773 amongst women. So men have the highest number, but thinking about females at 201,000+ is nothing to sneeze at. Tobacco smoking is estimated to lead to premature death. And here, premature death from smoking is defined as a death from a smoking-related disease in an individual who would otherwise have died later of another cause. On average, these premature deaths involve 10 years of life years lost. So that's significant as well, 10 years, right? Quitting smoking before the age of 40, however, reduces the risk of dying from smoking-related disease by about 90%. Now we move towards age, gender, and ethnicity as it relates to smoking. Relative to non-use of tobacco, white, and these are middle and high school students, had a higher relative risk than blacks for tobacco use. So we see some disparities here. Whites and Hispanics had a higher relative risk than black youth for use of tobacco plus another substance use disorders. These racial differences in tobacco use did not change over time. So we see the data here from 2011, 2013, 2015. The types of tobacco products used has varied by year and race. So in 2015, as an example, e-cigarette were the most commonly used product among youth from all racial groups. And so we saw in 2015 that significant spike. Evidence supports that cigarette smoking is significantly lower amongst non-Hispanic black youth compared to whites. Again, we must pay attention to what the data is saying so that we can be data-driven and evidence-driven. In terms of American Indians, Alaskan Natives who are non-Hispanic, in 2019, 20.9% of Alaskan Native American Indians adults in the U.S. smoke cigarettes, 20.9% smoke cigarettes, compared with only 14% of U.S. adults overall. So again, you see this population and the disparities there in tobacco use. Alaskan American Natives, Alaskan folk have a higher prevalence of current smoking than most other racial ethnic groups in the United States. Again, this points to issues of disparities. American Indians, Alaskan Native men and women were found to have a higher percentage of smoking-related deaths from heart disease and stroke than white men and women. Once again, drawing attention to those disparities. When we look specifically at Hispanic, Latinos, or the Latinx population, the prevalence of cigarette smoking among Hispanics is generally lower than the prevalence among other racial or ethnic groups in the United States, with the exception again of non-Hispanic Asians, right? It's important to note that. However, smoking prevalence among Hispanic men is significantly higher than among Hispanic women, and there are significant differences in smoking prevalence among subgroups within this population. In other words, we want to be careful not to lump all Latinos, Hispanics, or Latinx together, and you see the differences here by way of gender. Hispanic men different from Hispanic women. Among both men and women, smoking prevalence is highest among Puerto Ricans, and the lowest is among Central or South Americans. Again, not to paint with a broad brush, and understand that the Latino community is very diverse. In terms of the experience of lesbian, gay, bisexual, and transgender people, or folks from the LGBTQ community, smoking prevalence amongst this population, these individuals in the US, is higher than amongst heterosexual straight individuals. This may be in part due to the aggressive marketing of tobacco products in this community. So it could be related to that. Some of the data suggests that. In 2019, the prevalence of current cigarette smoking amongst lesbian, gay, and bisexual adults was 19.2%, compared with 13.8% among the heterosexual or straight adults. Again, what we see in these data are disparities between the LGBTQ community and the community that identifies as heterosexual or straight. Things to consider when thinking about program planning, implementation, evaluation, those sorts of things. Another subpopulation that we looked at are adults with disabilities. And they are more likely to be cigarette smokers than those without disabilities. That's a very important fact. In 2019, the prevalence of current cigarette smoking amongst adults with disabilities was 21.1%, compared with 13.3% among adults with no disabilities. Again, pointing to very important disparities in prevalence of tobacco smoking in the US. And so when we see disparities, we want to make sure that we're leading with equity and that we lead with strategies and techniques that prioritize populations that are experiencing disparities. In terms of people with mental health conditions, here is yet another subset of the population, right? Approximately 1 in 4, or 25% of adults in the US have some form of mental illness or substance use disorder. And these adults consume almost 40% of all cigarettes smoked by US adults. Again, 25% with some type of mental illness or co-occurring substance use disorder, yet they consume 40% of all cigarettes. This is a significant area to pay attention to as we design programs for different populations. In 2019, going back to that data, 27.2% of US adults with any mental illness reported smoking cigarettes during the past month, compared to 15.8% of adults with no mental illness. So you see that these numbers are high for folks who are experiencing mental health conditions on the ground. Coming now to the etiology of substance use disorders and looking at social cultural factors. Tobacco-related health disparities still exist for communities of color. So we are still dealing with these challenges. Latinos are the least protected group in terms of secondhand smoke in the workplace. But think about that, the least protected group in terms of secondhand smoke in the workplace. So that is not just people who smoke that we're paying attention to here, is people who experience secondhand smoke, which we know is that kills a lot of people as well. A number of indicators of assimilation to US culture, as well as social demographic variables, predict substance use amongst Hispanic. These include gender roles. An example of a gender role in the Latino community is machismo. This is attributed to Latino males. English language proficiency is another one. Regional differences in patterns of substance use amongst and within groups of Latinos. Remember what I said earlier, not all Latinos are the same. We need to take a look at smaller subsets of groups, subpopulations, that sort of thing. And then immigrant generations at higher risk for mental health problems. Another piece to really think about in terms of indicators and impact. And then access to treatment. We know that the data says that Latinos have less access to substance use treatment and must wait longer to access such services as compared to non-Hispanics in the US. Some of the disparities in treatment that occur within the Latino community can be resolved through increased availability of culturally informed treatments. So it's not just access, it has to do with quality of care. And we're drawing attention to access, quality of care, and what the experience of Latinos are, if you can take into account issues that include language and those sorts of things by way of access and quality of care. Now we're shifting here to treatment of tobacco use disorder in Latino populations. That's the shift that we're making. So tobacco is a legal drug that kills many people, many of its users, when used exactly as intended by the manufacturer. Think about that over and over again, right? Tobacco is a legal drug that kills many of its users when used exactly as intended by the manufacturers. This is huge. Data from 2019, the World Health Organization announced that tobacco, examples here include cigarettes, pipes, cigars, water pipes, smokeless tobacco products, and heated tobacco products, but not e-cigarettes, just to point that out, kills up to half of its users and more than 8 million people each year, of which 7 million are a direct result of tobacco use, right? So if it kills 8 million a year and 7 are direct use of tobacco, the exposure to secondhand smoke accounts for over 1.2 million deaths amongst non-smokers. It has impacts from when we're thinking about how do we design, implement, and evaluate programs that educate everybody and protect everybody, including children, including families, significant others, those sorts of folks who don't consume tobacco products but are exposed by the person who is. In terms of treatment for tobacco use disorders and the tools that we have available, most, if not all of you, hopefully have heard of nicotine replacement therapy. We have a vaccine in development. We have Chantix, which is the gum that people have been using. And we have Wellbutrin and Zyban also as treatment tools at our disposal. We're going to go a little bit deeper into these. We know here you see the sending neuron and the receiving neuron, and we see the receptors and the dopamine receptors, the nicotine receptors, and we see from this depiction how this model works in terms of sending neurons, receiving neurons, how things attach to one another, and the opportunity to intervene with medications that work effectively at blocking some of these things, right? So in terms of nicotine replacement therapy, the aim of NRT is to replace the nicotine that people who smoke usually get from cigarettes, so the urge to smoke is reduced and they can stop smoking altogether. NRT improves a person's chances of stopping smoking, and people use it to quit. Using the nicotine patch as an example, plus another type of NRT, such as a gum or a lozenge, together made it 15 to 36% more likely that a person would successfully stop smoking if they used only one type of NRT alone. So you see that when we combine these interventions, they have greater efficacy and probability to help people stop smoking. That's important for many different reasons. In terms of the vaccine that I mentioned earlier, vaccine development is another area of exploration in smoking cessation. The primary mechanism of vaccine would consist in generating antibodies that bind to nicotine to reduce its entry into the brain. And you see here the condition or disease is smoking cessation. The intervention or treatment is biological. You see the NICVAX conjugate vaccine, the biological placebo, and you see phase 2. So these things are under development. More to come on these things in the future. It's important for all of us as providers, as people who provide services and education, to understand these developments so that we can better educate the folks that we work with. Here we come into sharing a little bit more. Chantix is a medication. This medication is well known as Chantix in communities and via commercials and that sort of thing. It is a medication that aids in smoking cessation by acting as a nicotine receptor partial agonist. It's one of several first-line medications recommended to increase long-term smoking abstinence amongst people who want to stop. So you see, again, the depiction here in terms of how these medications work. More to follow on these. We have Wellbutrin and Zyban, also well known to many people. First non-nicotine drug treatment approved by the FDA, that's the Federal Drug Administration, to stop smoking, to help people stop smoking. An antidepressant that stimulates neurodegeneric and dopaminergic functions. It has been shown to double abstinence rates even in long term, which is why it is used as a first-line drug to treat smoking. It is not, however, indicated in smokers with a history or risk of seizures, or in pregnant or parenting, pregnant and breastfeeding women, I should say. So once again, those are the two medications that we're talking about there. Once again, here you see the visual in terms of what the bloodstream looks like, what the neurons in the brain look like, and how these medications enter into the bloodstream and work on people who want to stop smoking. So here's what we've learned in the second module as a summary. We know that in 2019, an estimated 14% or 34.1 million people, adults in the US, were current cigarette smokers. Current cigarette smokers were defined as people who had smoked more than 100 cigarettes during their lifetime and continue smoking cigarettes either every day or some days. So you don't have to smoke every day to be considered one. The prevalence of cigarette smoking among Hispanics is generally lower than the prevalence among other racial and ethnic groups, with the exception of non-Hispanic Asians. Once again, drawing their attention to disparities in this area. The aim of NRTs, these are the treatments that we talked about earlier, is to replace the nicotine that people who smoke usually get from cigarettes, so that the urge to smoke is reduced and they can stop smoking altogether. NRT improves a person's chances of stopping smoking and people who use it to quit. And remember what I said earlier, that we know from research that when there's a combination of drugs being used at the same time, people have a greater risk of stopping smoking altogether. So we want to, once again, thank you for logging on, taking in Module 2, and we encourage you to watch the other modules as well, and to share this information with other folks that you know, as well as the people that you are treating. Thank you once again very much. Muchas gracias.